breastfeeding. Okay, so the first 1,000 days are also a critical window of opportunity for us to very important and last and when mother's milk is not sufficient or direct breastfeeding is not possible, the next question is what can be done? And that is going to be answered by the next presenter. Thank you very much for listening to me.
Okay, thank you so much, Dr. Dory. Like the people in the chat have mentioned, that has been a very, very, very informative presentation. Apologies.
Our objectives today are just simple. We're going to know what is breast milk feeding is, what is breast milk expression, and how should we handle and store our breast milk. So after knowing the objectives that we're going to know about breast milk feeding, breast expression, and how to handle and store the expressed breast milk, let's go straight to our first main objective as breast milk feeding. Under this, we're going to see the methods of breast milk feeding, the signs of successful feeding, the challenges faced, and how to handle them. So now, number one method is direct breast milk feeding. This is when the baby can be able to suck, swallow, and breathe at the same time. So on this moment, the baby feeds directly on the mother's breast. So what is our role as health workers? To monitor this mother to see if the baby is lunching very well. If the baby is not lunching very well, it's our role to help them on how to lunch on their breasts. So under this, we are having different positions that will help us to lunch very well on the breasts. Number one is cradle hold, but this is more best when the baby can hold his head properly. we put the under the arm of the mother. Then the baby's mouth is brought to the mother's breast. There is even lying position. This is mostly used again when the mother is comfortable with the position or when the mother has done cesarean section so that we can so we are continuing with the positions. I was explaining about the lying position. This is when the mother and the baby lie facing each other. It is mostly used when the mother has been done cesarean section because we don't want this pressure of the baby to be on the mother's stomach. Or sometimes there are our mothers who are having a lot of breast milk. The moment the baby goes on the breast, there is much pressure that will end up causing choking. So when the mother is lying on the left, the floor is a bit more and the baby can breastfeed very well. So there are some photos that are showing the cradle method. As you can see, there is cross cradle, then football, and the sideline. So there is this friend of ours, the cup and spoon feeding. It is so challenging in that most of the time these babies take a lot of time to sip this milk, and sometimes us health workers want to rush. Please and please, if you are going to feed this baby with spoon or cup, we have to be patient. Don't rush. This method is mostly used when the baby can swallow. Never use this method if the baby can't swallow. So if the baby can swallow but lacking the sucking reflex, here we go with spoon or cup feeding. So this one, it is used mostly to preterm babies who can swallow. Babies temporarily separated from their mother. So if you are there, the mother can't walk, the mother is a bit sick, you just tell this mother to express breast milk, then you hope and feed this baby. Don't leave the baby to cry because the mother is not there. Then babies with abnormalities, they can also use this spoon feeding with cleft palate. You can be using this spoon feeding until when surgical is done on the baby and the baby can feed later. There is this baby with cerebral palsy, they have that slow motion of swallowing. So we can use cup feeding so that our babies can get the nutrients of breast milk. So it is also used when giving oral experience while the baby is on NG tube. We don't want our babies to be NG tube dependent. So we try to initiate the swallowing reflex by starting using the cup or the spoon feeding. So how do we prepare? We have to wash hands. Washing hands is very key. Because you are a health worker, it doesn't mean that you should don't wash hands for you are sterile. No. Before you go to handle the baby's milk, we have to wash our hands first. And we have to use clean cups or shallow spoons. Don't bring a big cup for an adult because as a medical worker for you, you know you can use any available resource. No. If you are having a big cup, no, don't use it on our baby. Baby is still small and the mouth can't handle that big cup. Get a small cup. You can use these covers on syrup bottles, or you can try to find those small cups that can help feed our babies. Then after cleaning our hands, we have got our cups. Then you have to hold this baby upright or in semi-upright position. Never feed the baby while lying flat. The milk is going to flow back and we shall end up with aspiration. So you have to make sure our baby is in sitting up position or in the same upright position. Put the baby on your lap and the head should be supported, slightly extended, as you are seeing in that picture. Rest the cup, rib, or spoon on the baby's lower limb. Don't put the cup on the upper part, but put it at the lower limb. Then treat just enough so that the milk touches the baby's lips. Don't just push it, because all the milk will just enter in the nose, in the face, and splashes anyway. So you just stir it slightly, then allow the baby to sip the milk slowly. Don't just force because for you want to do something, you have another baby to feed. No, remember we said here we need patience. Then don't pour the milk into the baby's mouth. Let the baby just feed on her soul. So you have to be patient. After feeding, hold the baby upright and bang. Don't just put the baby back to the incubator because the milk is going to come back and the baby is going to aspirate. So our don't see here, never feed the baby when the baby is asleep. Then don't continue to feed the baby if the baby is coughing. The moment the baby coughs, you first wait. Why do you rush? First wait. When the cough ceases, then you start. Then again you have to ask, why is the baby coughing? Because it could be the baby has choked. So never pour milk directly in the baby's mouth. Let the baby take the sip on her own. Now, there is another friend of ours called nasogastric tube. What is a nasogastric tube? It's just a thin, soft, and flexible tube. Passes through the nose, down to the throat, into the stomach for feeding. When do we use this type of feeding? In premature babies, those small, tiny ones, 500 grams, they don't have that sucking and swallowing reflex yet. The low birth weight infants, then babies with the abnormalities like breast palate, and the critically ill term babies. So, how do we prepare for another gastric tube feeding? Remember, we said hygiene is key. We have to wash our hands first. Otherwise, we shall always continue to say the baby is having infections, and it will be you who is introducing these infections to our baby. So make sure that tube is safely in the position. Don't think that the moment the tube was inserted in, will be always inside from day 1 to day 10. No. Before you're going to feed that baby, make sure you first check, is the tube still inside or it has leaked out. Remember, when we insert these tubes, we mark where the tube has, and then we put the strapping on the nose. First check, is it there? Is the strapping still tight or it is loose? Then, after that, you have confirmed the tube is still inside, confirm the volume of milk prescribed for the baby. Don't just give, because these preterm or these critically ill babies, there are some measurements they take. Then allow the milk to warm if it has come from the fridge. But if the mother just expressed the milk there and then, just give it to the baby because it is at its normal temperature. Then prepare the feeding syringe. Pour the prescribed volume in the milk into the syringe or draw it. Allow the milk to enter by gravity. So when you bring that milk in the syringe, connect it on the tube. So when you connect it on the tube, make sure it goes down there by gravity. Don't force it. If you put it up and you see the milk is not going, just know there is a problem. So make sure you first select that problem. But if the milk goes slowly by gravity on its own, you are well to go. You can continue with the feed. So ideally, in the nasogastric tubing, we should feed these babies while in their mother's chest in kangaroo position. Why? Because this baby is getting the warmth from the mother, the baby is already in a sitting up position, so the milk will just flow properly. And even you will see the breathing and heart rate normally posing very well. And also, this baby will gain weight. Why? Because there will be less fetal. There is no way the milk will come just up and flow down. So all the contents will be digested in the baby's stomach. So after feeding, make sure the baby stays there. The baby stays there in the position for at least 30 minutes so that we can avoid the milk to come back and prevent aspiration. So if we can't, if this position is not, if the mother is not on the ward, but it's time for feeding, make sure you elevate the baby's upper part by either 30 to 50 centimeters. Okay? Then you follow the procedure. After feeding, leave this baby there for at least 30 minutes. Don't just lay back the baby because the baby is going to aspirate. The milk is going to just come back, then the baby is going to aspirate. So the important key to monitor during any tube feeding, watch the breathing. If the breathing changes, just know maybe the tube is in the lungs. Make sure you stop and do the needful. Observe the baby's face. They can change to blue color. If there is choking or coughing, maybe the tube is not in the right position. Watch for vomiting. Maybe you have not elevated this baby so well and the milk is just coming back, or the tube is not in the right position. Watch the bed of the baby. Yes, after feeding, the stomach has to increase a bit. But if there is that abnormal swelling, at least call in the doctor to see what is going on. If the baby is desaturating during the feed, just to know the baby is aspirating. Stop there and then and do the needful. So increased secretions, we also have to monitor that. So what are the signs of successful feeding? The baby just stays calm and comfortable, like the feed, just not now, we're on a good track. If there's active swallowing, either you can see it, most especially when you are using a cup or direct feeding, or you can hear a sound when these babies are swallowing, in most especially when they are on direct feeding. The feeding is completed on time without distress. Baby appears satisfied and sleeps after. So, steady weight, ideal 15 grams per kg per day. So when you weigh your baby, that there is no additional weight, just to know maybe there is something wrong, they have to investigate and deal with it. So regular weight diapers. If you see after feeding the baby, diaper is full, you are on the right track. What are the challenges we face? The challenges, number one is difficult lunching. It is very difficult because sometimes these babies, they can keep sleeping, they can open mouth just a bit little, but you just have to tickle the baby's lips. The baby will open the mouth widely and connect the baby on the breast. Just bring the baby to the breast, not the breast with the baby, and make sure or the oral areola is entering in the baby's mouth, not the nipple. Then the sore or cracked nipple. This is caused because of poor lunch. If we lunch very well, our babies, no sore nipple will happen. Breast engorgement. Just get a warm towel, massage the breast with it, and express that milk out. You'll feel so good. The low milk supply, you have to get enough rest, frequent emptying of the breast, and enough drink. Don't think that just drinking enough will be having a milk. If you drink minus emptying the breast, you feel like someone who is not breastfeeding, who is drinking on his normal days. So you have to aim to alert the mind that there is someone who is feeding will need more production. You have to rest. Just imagine yourself, you are stressed, you can drink even something you want and fail to do it. That happens because the stress hormone has covered any other hormone. So we have to relax our mind so that we can make our hormone at a good point so that breast milk can be formed. The blocked duct is just a matter of express that pressure opens them or you clean them, they will open. When the baby is falling quickly at the breast or during spoon or cup feeding, just gently trickle the baby's palm or the soles of the feet or the back. So returning to work, you have to express this breast milk and store it as long as you have a freezer or a fridge at home. So now let's go on breast expression. We're going to see why we need it and how to express it safely. So why do we need this milk expression? To relieve the engorgement, as I said before, to express our milk for the babies to whom we are separated with the babies immediately on what milk, maintain milk supply well, not breastfeeding a baby. Don't just stay there because the baby is not breastfeeding. You fail to express the milk. If you can't express this milk, just know the milk won't be there. We have to make our mind alert that we need this food. So, however much the baby is not with us, however much the baby is not feeding at that particular time, we have to express this breast milk. Leaving the milk to the caregivers or milk donation. So how do we express? We are having our hand expression. This is just simple, effective, and at a zero cost because everyone has a hand. we have to wash our hands first with soap before expression. If the nipple or breast is visibly dirty, gently clean it with a clean water. Then you have to massage gently in a circular motion. You can either use your hand or you can get a warm towel and massage, because when you use a warm towel to massage this breast, it will easily flow. And when the breast is swollen, it will just make it a bit simpler and you will be able to express this milk out. Then you have to press your thumb finger about 3 to 4 centimeters behind the nipple, forming a C shape. Then you press inwards the chest, then compress and release. Express and empty the breast. Don't leave some milk, because the baby is taking 2 meals, 4 meals. Tell this mother to express and empty the breast so that the breast can be refilled for other feed. So as we are seeing there, the mother is expressing using the hand, but someone is helping her to hold the cup. Then preparing to express, you have to be with either a spoon if the mother is going to feed there, and then be with a spoon or a cup. They have to be cleaned with soap and water, and they have dried at a room temperature. Then if the breast is dirty, you clean it. So besides, we are seeing how to do hand washing. You have to first wet the hand, then you put soap, then you clean, you first rub the hand, then you backward, then you twist the fingers, then you have to focus more on the nails. Then you can do it for 20 minutes before you start the procedure. So as we are seeing there, the mother is expressing using the hand. She will massage it first. Oh. So there is another method of pump expression. You can either buy manual pump or electric or wearable. If you have money, the procedure remains the same, only that here we have to assemble the pump parts. And after using them, we have to clean them and leave them to dry. So let's see how to handle army by storing it in the fridge. First of all, we have to wash our hands. Remember, you have express army. Wash your hands. Make sure you have a clean bottle with a secure lid. Don't just store the milk when the milk is not sealed very well. Label the milk correctly with date, time, and name. Always tell these mothers to label the milk by putting their name. If the baby has a name, well and good. If the baby has no name, let the mother put her name there. The date has expressed the milk and the time. Why? Remember, we have to do first in, first out. This one will help you to know which milk she expressed first. Then, after that, this milk has to be stored in a fridge for only 72 hours, meaning 3 days. Beyond that, you're going to discard this milk. If after you are having a bank at your site and they have sent in milk from the bank, this milk that has been stored must be used within 24 hours. If a mother has freshly expressed this milk, it should be stayed at the room temperature for only 4 hours. So remove only the prescribed amount of milk to be fed at a particular time. That's the milk you have to warm if it has been in the fridge. You can either warm it or you can put it at a room temperature. Then after, give it to the baby. So signs of unsafe milk. You can just see and hear the unusual smell. That one we just know that this milk is unsafe. Discard. The bottle is leaking, damaged, or contaminated. Just pour the milk. Label is missing or unclear because you can't know whose milk. These mothers sometimes they can tell you that the milk is mine, yet the milk is not hers. Make sure always tell these mothers that they should not take anyone's milk apart from the milk got from the milk bank, because the mothers are sick. You have to tell them as they express the milk, you have to tell them as they visit the unit so that they don't do a mistake of taking other mothers' milk. And you have also to emphasize them to label the milk so that you can also identify this milk if it's the time for feeding their babies. So the milk has to be in a fridge for 72 hours. In conclusion, successful breastfeeding and proper positioning, that is lunching, help the baby to get all the nutrients and the mother will be able to get more milk. Only infants with safe suck and swallow can breastfeed directly. Mothers must be taught and supported to extract their breast milk when direct feeding is not possible. So collective storage and handling practices are key to preserving milk safety and quality. Thank you very much, our listeners.
Wow. I think we all agree. Miss Caroline has done a very good job. I think we can clap for her in the chat. Thank you so much, Carol, for that wonderful presentation. I'm sure everyone has understood, and we're going to do better for our neonates and any other children that will need this. So thank you for the questions that we are seeing in the chat. Like we said, we have an expert that is Dr. Tom that will be able to answer all those questions in the chat. And for those questions that will not be answered, we shall be able to go through them towards the end of our session. For our next topic on the agenda, that is human milk banking. And our discussant for this topic is Dr. Kathy. Dr. Kathy is pediatrician, neonatologist at Mbale Regional Referral Hospital. I think any other details about her should be able to explain before she starts her presentation. Dr. Kathy, the floor is yours. As Dr. Kathy comes up, kindly stop registering your license numbers in the chat. We are going to send a link at the end of the discussion where you'll be able to register, because once you do that, you won't be able to get the points. Thank you very much. Dr. Kathy, please, you're welcome. The floor is yours.
Amazing. Thank you very much, Dr. Caroline, and thank you, Sister Caroline Doreen, for the amazing talks leading up to this. It's an absolute pleasure to be here this afternoon to talk to you about the role of human milk banking. Apologies for not being with you in person. I'm currently out of country for 4 weeks. So greetings from a very cold and wet Norway, where I'm sitting today. So as I was introduced, I'm Dr. Kathy. I'm neonatologist at Mbale Regional Referral Hospital. And today I want to take you through a few things. We've heard about breast milk, we've heard about breastfeeding. Caroline has taken us through what to do if we can't directly breastfeed our babies, how we can get that milk out of the mum through expression, and how we can give that to the baby with a cup and spoon or a small cup or a nasogastric tube. So I'm going to take that now one step further. What do we do when the mother's own milk, we call that mum, Doreen has described that for us, when it's not enough? What is donor human milk and where does it come from? How do we make donor human milk, or how do we process it? And when do we actually need to use donor human milk? And then just a little bit at the end, we'll talk about when we did this in Mbale over the last few years, what was the impact and what is the hope for us as a country in Uganda for donor human milk and lactation support as we move forward. So many of us on the call will have had an experience of looking after a preterm baby in Uganda. And I think it would be fair to say that for most of us, and even in Mbale till a few years ago, pretty much our standard was admit the preterm baby. We'd start feeding within about 24, 48 hours. And by that, I mean, go and buy a bucket, go and buy a cup and press your milk in that cup. Maybe we'd pass the NG tube, the nasogastric tube that Caroline has talked to us about. And then we'd ask the mother, can you just press 4 mils an hour or 10 mils an hour and give that to your baby? But most of us have a lack of resources, lack of human resources, most especially, and don't really have the time available to sit and support our mothers to express their breast milk and show them how to feed. And actually, most of the feeds for our neonatal units in Uganda are done by the mothers themselves. And really our only measurement of how well we're doing is the weight of these babies that many of us will take every 1 to 2 days. So we've seen some of these videos already. It's very typical, like we have seen, for our mothers to express their milk by hand. Very few mothers in Uganda will have access to electric pumps. And indeed, if we're sharing pumps, they should be hospital grade, which are even harder to come by. That said, hand expression is an excellent way to get out breast milk, most especially in the first few days after birth, really is much better than using a pump. And then we have these key methods, feeding with the nasogastric tube, or for the bigger babies or the babies who are for respiratory support, we can use a cup and spoon. Now, how successful is this approach? You may ask yourself. We all do it. We all approach feeding for preterm infants in this way. A few years ago, one of our PhD students in Mbali, she undertook a study. She pulled all the medical records of our very low birth weight babies. That's our babies under 1,500 grams. And she looked at the outcomes. So unfortunately, of those very low birth weight babies, 41% of them were already what we would call growth restricted at birth. That means that even inside the mother, they've already failed to grow, damage to the placenta, maybe from malaria, maybe from pregnancy-induced hypertension, maybe the mother herself was malnourished, but already at birth, 4 out of 10 preterm babies are already undernourished. And by adopting that approach that's familiar to so many of us on this call today, by discharge, 75%, that's 3/4 of our preterm babies under 1,500 grams, had what we call postnatal growth failure or postnatal growth faltering. So essentially, when we adopt that approach, we are not getting enough of mum's own milk to the baby, and indeed mum's own milk on its own is apparently not enough. So globally, there's various options that are available to preterm infants, and indeed in high-income settings, they've had huge success in improving the postnatal nutrition of these preterm infants. One way is to use something called TPN, that's total parenteral nutrition. And by that, you have a bag of fluid, like you can see on the slide, that contains different electrolytes, proteins, maybe even lipids, that supports the nutrition of the baby. It can be idealized individually for a single baby, or you can just buy a standard bag of TPN that is generically good for any baby. But even those standard bags cost around $65 a day, far outside what most of our patients in Uganda can afford. And if we want to administer that TPN, we need what's called a long line. That's an extra long cannula that will go in, and the tip will end close to the level of the heart. Those long lines are expensive, they require special skills to insert them, and they're also high risk for infection and causing severe sepsis in our babies, something that many of us would not want to try in some of our neonatal units where IPC is not as good as perhaps it should be. There's also another option, it's called Breastmilk Fortifier, and indeed we do have Breastmilk Fortifier in Uganda. But on average, if we were to use Breastmilk Fortifier, that is a small powder that you add to the breast milk of the mother herself. If we were to use that for the preterm babies up to around 32 weeks, each baby would cost us around $200. The other things to know about Breastmilk Fortifier is although it improves the growth of our preterm babies, it can also increase the risk of necrotizing enterocolitis, which Dr. Dorian has already described to us, and also sepsis, hospital-acquired infections. So maybe you might say, well, what about formula milk? We can go to the supermarket in town and we can buy formula milk. Why not just top up our babies when mum's own milk is not enough with formula? Well, when we compare babies, preterm babies who have received any amount of formula, whether just formula or formula top-ups, what we know is that it increases the risk of necrotizing enterocolitis. This is a tiny preterm here on the screen who's suffering from NEC. NEC is inflammation and infection of the gut, and even in a high-income setting will have a mortality of maybe around 25%. And for many babies in settings like ours in Uganda, the mortality is much, much higher. We can also see from the graph that those babies who have breast milk compared to formula milk have much lower rates of hospital-acquired infections or late onset sepsis. We've heard mentioned earlier about retinopathy of prematurity. That's a disease of the eyes of preterm babies which can lead to blindness if not prevented or not treated. But we know that babies who take breast milk as opposed to formula milk have a much lower risk. And again, we know if we feed with breast milk rather than formula milk, these babies have much lower risk of refluxing and vomiting and therefore aspiration. And babies who are born premature, their brains are not yet developed. You can see how the brain folds between 27 weeks and 38 weeks in this picture on the right side of the slide. And we know that babies who are fed breast milk after they're born, their brains continue to fold much more similar manner to had they been growing inside the mother up until 38 weeks. And brains that have more folding actually equates to better cognition, and that means better neurodevelopment when these babies reach 12 months, 18 months of age. So what can we do? TPN is expensive, potentially dangerous for us. Breast milk fortifier is there, but it's also incredibly expensive. And yet we've seen in those early slides that actually 3/4 of our preterm babies are suffering from essentially malnutrition by the time they go home from our neonatal units. Well, one of the most simple things that we can do is we can supplement the nutrition of our mothers. Many of you on the call today, and there are many of you here, will have breastfed or know someone that breastfed and know that they eat a lot of extra food in order to breastfeed. Mothers who are undernourished or malnourished really do not produce the same quantity of breast milk or indeed the same quality of breast milk. Many of our mothers in our government facilities in Uganda, they don't even have enough money to be able to feed themselves correctly, often living off dry tea and perhaps just rice. That means that if we're able to offer them an additional meal each day, you can see here one of our implementing partners in Elgon region, Born on the Edge, they support our mothers at the malnutrition unit to take an extra meal every day whilst their infants are admitted to the neonatal unit. This is something all of us can work with our hospitals, our administrations, and various implementing partners to make sure that our mothers are supplemented with adequate nutrition to ensure that they can maximize on their breast milk. The other options we have are improved education and lactation support. These are some photos here on this slide of the approach that we've taken in Bali Regional Referral Hospital. So we have an expert mother, Goretti Ayabali, who you can see in 3 of these photos here. She is trained and certified as a breastfeeding specialist. Every morning she comes onto the ward and she teaches all the mothers, fathers, caregivers, anyone who is around about the benefits of breast milk, the benefits of breastfeeding, and also sensitizes them about donor human milk and human milk banking. In addition to that, the medical team are also allowed to refer babies and mothers directly to Goretti for one-on-one lactation support. Anyone who is just starting to express, anyone who is having challenges with not enough milk, anybody who needs support in learning to NG tube feed or spoon feed can be referred to the breastfeeding specialist who has dedicated time to support those mothers to be able to express and safely administer milk to their vulnerable infants. So I think it's quite clear by now, mother's own milk is best. It's fresh, it protects against infections, it helps growth of the gut and of the baby themselves, helps neurodevelopment. But it's not enough. And we know from the data in Uganda, in Mbali, that mother's own milk on its own is not enough. We know that we can't afford in general total parental nutrition or milk fortifier. And we've seen that formula milk is actually dangerous to give our vulnerable infants, most especially the preterm infants. So what about donor milk? Donor human milk could be an option. And indeed, WHO and UNICEF, they tell us the following. Where it's not possible for a biological mother to breastfeed, the first alternative, if available, should be the use of human milk from other sources. Human milk banks should be made available in appropriate situations. This was actually written by WHO and UNICEF in 1980. That's before most of us on this call were even born. And yet where we stand today, most of the countries in sub-Saharan Africa do not yet have a milk bank. So what is a milk bank? Well, you can see a video ongoing on the right-hand side of the screen here, milk frozen in our milk bank in Mbali. A milk bank is a facility that collects milk from other mothers, screens those mothers, pasteurizes the milk, and dispenses it to those who need it. Typically, milk banks are in high-income settings in Europe, North America, and they involve donation from the community. Mothers whose babies are a bit older, maybe they're 6 months, definitely term babies and not preterm babies. And the milk that Doreen described earlier, colostrum, transition milk, the milk that comes from a mother in the first 2 weeks after birth is what is much, much higher in protein, which is what our babies really, really need. By the time you've got to the community, we're looking at something called mature milk, where protein levels are much lower. So the question then is human milk banking possible in our setting? Well, any intervention that you're going to introduce needs to be acceptable. So one of the first things that we started with in Bali was a couple of qualitative research projects. Both led by med students, one from the UK and one from Busatima University, and looking at the acceptability of both giving donated human milk to your baby or donating your milk to a milk bank. Overwhelmingly, families were happy to give donor human milk to their infants when mother's own milk wasn't enough. And all the mothers who responded were very willing to donate their human milk if it was going to save the life of another baby. The common misconceptions that were highlighted in both of these studies was the misconception of non-communicable diseases. Not only did they fear transmission of things like HIV, syphilis, and hepatitis B, but they also feared the transmission of things like sickle cell disease and cancer. And some of them went further still and believed that you could transfer things like character traits, so intelligence maybe, stubbornness, those kind of things, kindness, could be transmitted via the milk, which I suppose could act in your benefit or otherwise. It was also very clear that they wanted the milk to be handled like blood is in a blood bank. They wanted it to be anonymized. They didn't want to know where that milk had come from. They would be happier to receive it should it just have a number on it. So what we knew then is that we needed to improve community awareness so that people could understand the benefits of donor human milk and we could remove any misconceptions that existed. So starting maybe 3 or 4 years ago, our advocates for milk banking and donor human milk, that's mothers, midwives, nurses, doctors, they're always on the radio, even just now in August, World Human Milk Week month, World Breastfeeding Week month, if there's such a thing. They have been on the radios talking to our communities, answering questions about the importance of breast milk, breastfeeding, and donor human milk. I mentioned earlier that in most human milk banks in the world, the donor human milk comes from the community. So when we started to think about setting up a milk bank in Mbali, we started to think about where we were going to get our milk from. Our mothers out in the community, we know too well, would need transport to come into hospital and bring us the milk, or we would need transport to go to the community and pick up that milk from their homes. But that, of course, would require ongoing financial input and would not create a sustainable model. We also had concerns about the cleanliness and sterility of expressing milk at home, and most of our mothers don't actually have a fridge, and even fewer have backup power to be able to maintain that cold temperature of any expressed milk. So we started to look within the hospital itself, and first we went to the postnatal ward. Postnatal ward, we have healthy mothers. Many of them, though, are just in the first day or so after delivery, so the milk supply is perhaps not as high. And many of them have also left within 24 hours. So if we take off their blood tests to screen them, by the time we have the blood results back from the lab, most of them would probably have already gone home. So we looked within the neonatal unit. Our neonatal unit might be busier than many of yours on the call, but there's always mothers in the neonatal unit. And there's always mothers in the neonatal unit who have too much milk. Maybe they have more milk than their baby requires, or maybe their baby is not allowed to be feeding because they're a surgical baby, or they've been stopped feeding for another reason, and they have nothing to do with their breast milk. The other great thing is that the mothers of neonates in the neonatal unit have, remember, that transition milk, the milk that is much more nutritious and much higher in protein than the term milk of the mothers who have gone home. So we thought that we had found a good solution. Preterm mothers as well as term mothers, but focusing on preterm donors within the neonatal unit within the first 2 to 3 weeks after birth would potentially have the most nutritious milk that's available. So every day we screen for potential donors. Mothers have to be more than 18 years or over. They need to have enough milk for their own baby, and they must be willing to donate that extra milk for free. We must never pay mothers for their milk. They may give you something that's not milk, maybe cow's milk or other white liquids. And they may also give you their own breast milk at the expense of their own child if they know that there's money available at the end of it. I'm not going to take you through in detail the other reasons that we exclude. There's a long list there, but it's important to say that these mothers must be healthy. They mustn't be on medications that are contraindicated. They mustn't have HIV, hepatitis B, and syphilis, and they mustn't be smokers on alcohol or be taking drugs of any sort. Like I said, we were worried about how mothers might express and how clean it might be in the community. So within our donation in the hospital, it's directly supervised. You can see the breastfeeding specialist there supporting one of our donor mothers to express her breast milk into an autoclaved, clean bottle that we are going to then use in the milk bank. Can, of course, use single-use sterile bottles for such purposes, but not so sustainable and definitely not so good for the environment. Once the mother has expressed, that milk will be labeled with her donor number, the date she's expressed, and whether she has a preterm infant or a term infant, immediately placed in the fridge and shortly after, within 2 hours, into the freezer. Just very briefly show you this. This is an area in one of the corners of our neonatal unit, but we basically, just to show that you don't need a lot to start. We created our milk room, and this milk room is for counseling mothers who don't have enough milk, counseling our donors, and also for mothers to express their breast milk in private, whether they're donating or whether they want to express their own milk for their own baby. These 6 bottles here are then the donor human milk that is going to end up in the freezer. Once in the milk bank, the milk is stored at -20. We have 2 separate freezers. We separate the unpasteurized milk from the pasteurized milk. So there's very limited chance that you could interchange the 2 kinds of milk. Within those freezers, we separate milk from preterm mothers from term mothers so that we can try and prioritize the highly nutritious preterm milk for the preterm infants. Backup power for all of us is key. We know how Umeme works and it's not always present. So you need to have a backup power to make sure that you don't lose your whole bank of liquid gold. And within each of our freezers, we have 3 Wi-Fi connected thermometers that are connected 24/7, connected to 4 members of the team so that if the freezers go above -15, all 4 of those members are alerted and we can identify what the problem might be before the milk is thawed and spoilt. The milk then at some point will be pasteurized. There's 2 methods for pasteurization and both of them are very good. Neither is better really and neither is worse. Holder pasteurization heats milk for around 30 minutes to a high temperature. Primarily both of these methods are to get rid of bacteria and viruses, but this method requires continuous power, continuous water, and also costs around between $10,000 to $30,000. There's another method of pasteurization, short time, high temperature. So we heat it up to 72 degrees for 15 seconds. And this method is believed to be less damaging to the breast milk, doesn't destroy so many of the good things, but indeed still removes the bacteria and the viruses. The good news is that systems like this cost less than $1,000. The bad news is it's quite time consuming and it needs somebody to undertake the pasteurization continuously. So you can see Goretti here in the milk bank. She's able to pasteurize 3 bottles at any one time. So within an hour, let's say she can pasteurize around 12 bottles. So we have managed in Bali where we have maybe around 10 babies on average donor human milk at any one time to sustain the milk bank using this manual method and affordable method of pasteurization for the last 3 years. Once pasteurized, the labels come out with the donor number, the expiry dates, the date of donation, and we check that the pasteurization curve is actually as we expected. Once again, the milk is then placed in the freezer at -20 and it's kept there until it needs to be dispensed to a patient on the ward. Dispensing is done by the breastfeeding specialist after we have realized that lactation support is not enough. So they have the general education, they have one-on-one lactation support, and if still the mother is not able to produce enough breast milk, or indeed the mother is in contraindicated drugs herself, or the mother is too sick or has passed on, then we will offer donor human milk as a top-up. And we prioritize infants under 32 weeks, those are highest risk of using alternatives like formula. And as you can see, we go up to higher weights. So what has been the impact of this study, or the study of this intervention? So as we introduced this intervention, we repeated a similar analysis of the medical records within the neonatal unit. And over the first 1 year that we were practicing this bridge to breastfeeding program, we looked at the outcomes of all the preterm infants under 1,500 grams. And what we found is that over half of our mothers of very low birth weight babies, even after this generalized breastfeeding education, were able to produce enough breast milk for their baby. Another 25% did indeed require one-on-one lactation support, but after sitting with a breastfeeding specialist, they too were able to produce enough milk for their own baby. Another 19%, even after that one-on-one lactation support, still didn't have enough milk for their baby, but we were able to top them up with donor human milk while simultaneously providing lactation support, topping up lactation support, until by the time they went home from the hospital, they had enough of their own breast milk to sustain their baby. Less than 1% of our babies did not transfer to mum's own milk. And that was because in one instance, the mother had passed on, and in another, the mother was still too sick. Those babies ultimately did go home on formula milk, but they did receive the benefit of donor human milk throughout their admission to the neonatal unit and the benefits that come with that. So if we go back to some of the earlier slides, you'll remember before we started Bridge to Breastfeeding, around 3/4 of our babies were having postnatal growth faltering or malnutrition by discharge. In the first year after we implemented Bridge to Breastfeeding in Mbali Hospital, we actually reduced this rate to 53%. Remember, around 40% of these were already malnourished at birth. So we're not perfect, but this is a huge reduction. If we look at it in a statistical way, which might not be familiar to so many of us on the call, but essentially this relative risk, this 0.7 means that we have reduced malnutrition or postnatal growth faltering in these preterm babies by 30%. That is a huge impact on these babies. And one of the most exciting things that has happened in Uganda, I believe, in the last 1 week or so, was last week on Wednesday, when an amazing team of individuals, lactation specialists, nutritionists, doctors, neonatologists, and pediatricians who've been working together over the last 18 months or 2 years, were finally able to launch together the human milk banking guidelines for Uganda. So let's just quickly look at this map as we come to a close. I am currently sat up here all the way in Norway. You can't see Norway or Europe for that matter because of the number of dots of milk banks that are covering Europe. Similarly in Brazil and also in the United States of America. But if we look at Africa in general, there's not very many dots there. And indeed, as we sit here now, there's 11 milk banks that are formally registered in sub-Saharan Africa. 5 or 6 of them are in South Africa, and 2 of them are in Uganda. That's in the Mbali Regional Referral Hospital, and together with Dr. Victoria Nachibuka in Sambia Hospital. So really, we have a long way to go. But I believe now with our national guidelines, we are going to get there. So as I leave you now today, the conclusion is for all of us, and we've heard it right from the beginning, from Doreen through to Caroline and through to this talk now, mum's own milk is best. We should always focus on getting mum's own milk for our babies. That said, mum's own milk on its own is not always sufficient for preterm and vulnerable babies. But I think, as you've very clearly seen from the data in Mbali Regional Referral Hospital, breastfeeding education and lactation support can help 80% of our vulnerable or preterm mothers and babies have enough breast milk. We can think about donor human milk. We now have the guidelines. But we should always think of donor human milk as a bridge to breastfeeding and not a replacement. So we should always still be continuing that breastfeeding education and lactation support while supplementing with donor human milk. Human milk banks indeed are potentially affordable and feasible in our setting. Mbali Milk Bank has been going now for 3 years and I believe is therefore sustainable. But I think it's our time for everyone on this call to use what works and to scale up lactation support for all our neonatal units, whether those of you on the call are in a health center 3, 4 district hospital, regional referral hospital, or indeed a national referral hospital. Lactation support is key to the success, not only for these preterm infants, but even those term babies who are just breastfeeding we heard about in the first talk today. And ultimately, we should be aiming to have human milk banking available for all our level 3 neonatal units in Uganda. So thank you all for listening. I'll leave you with a quote that Doreen started with from World Breastfeeding Week 2026. Breastfeeding for a sustainable start in life, strengthen what works. And thank you very much for listening.
Okay, thank you so much, Dr. Kathy. We all agree that was very beautiful. Thank you so much for such a powerful presentation. I'm sure everybody has picked something, as we shall see in our post test. That was very beautiful. Thank you so much. So our next session is the Q&A. Some of the questions have been answered in the chat by Dr. Tom, though I was able to pick those that were missed, and we're going to be able to go through them and give you feedback. Dr. Tom, if you could unmute, kindly unmute, I will be able to ask the questions as noted down in the chat. After that, you'll be able to give your closing remarks. Dr. Tom, are you still on the call? Okay.
Thank you. Thank you very much, Chair. And thank you, presenters, for that very, very wonderful presentation of breast milk feeding and its challenges. So I have, I think I tried to reply to some of the questions in the chat, but I think the one that probably I can cite a few, and then I'll give the presenters some chance to answer some of them. There's a question that I would feel Dr. Kathy should respond to, and that is, does the milk have food preservatives? Does it have expiry dates? And if so, how long does it take to remain safe for the babies in the bank? Is the milk sold or used in hospitals? What babies are indicated for the use of the milk? Does it apply to preterm babies without mothers or all babies? Is human milk bank replacing, I think, the breastfeeding? I think that one, Dr. Kathy may probably respond to it. And then there was a question on what causes poor weight gain despite adequate breastfeeding. It was raised by one of the participants. He asked a neighbor whom the mother believes is feeding adequately, but the baby is not gaining weight. The advice probably would give to that mother is that baby needs proper assessment and evaluation, because the causes of poor weight gain, despite feeding, are many. But the first thing to do is to, first of all, find out whether actually the mother is feeding adequately in terms of attachment of the baby, the positioning. Does the baby have other challenges that might that are preventing effective breastfeeding? Things like the tongue tie, maybe some abnormalities within the cartilage, cleft lips and cleft palate. Then the baby needs to evaluate it to find out whether there are other chronic illnesses that might be having that are preventing weight gain, infections like probably tuberculosis, HIV, chronic congenital heart disease, hyperthyroidism, and chronic kidney disease. And then also in terms of the neurodevelopment assessment, maybe the baby is having some challenges, maybe CP and other metabolic conditions that might interfere with weight gain on that baby. So the advice I could give is that mother needs to be evaluated, that baby needs to be evaluated by a pediatrician or a neonatologist for that matter, or any other doctor who is near, assesses and then maybe decides refer. And then there was a question on how long should HIV positive babies be breastfed? According to the Uganda recommendations, actually, exclusive is supposed to be from 0 to 6 months, and then you continue, add complementary feeds, but continue breastfeeding for at least 12 months, depending on the condition of the mother. Otherwise, even going up to 2 years is not bad, but avoid mixed feeding in the first 6 months of life. And then there was a question on the mother has lost the baby in the first 1 month. Now, do we control the milk let down or the milk engorgement. Ideally, when the mother loses the baby, there are some drugs which may be given, but if I say, okay, that those drugs that suppress the production of prolactin, that will help to reduce on the milk letdown. Drugs like bromocriptine, I think is common in our setting, but can also use cabergoline if it's available. But you should be able to advise the mother to do expression of the milk in terms of engorgement, and then do cold packs. The mother should wear a comfortable bra that does not overstimulate the nipple, because once the nipple is stimulated, it also stimulates the hypothalamus, and the hypothalamus stimulates the anterior and posterior pituitary glands, which will lead to the release of oxytocin and prolactin, which will increase the milk production and also the milk letdown. There was also diabetes, the relationship between obesity and breastfeeding, and also diabetes. You realize that there are so many factors that can, why breast milk is protective against obesity and probably milliliters. You realize that when a baby is breastfeeding, there are usually regulators within the breast milk that control appetite. That is the leptin and not adiponectin. So these hormones control appetite, so that when the baby is satisfied, the baby will stop breastfeeding. And also they don't lead to over release of insulin. But these other milk products, maybe the formulas and the cow's milk, whatever, when the baby feeds on them, the carbohydrate levels are very high, and usually there is increased release of insulin, which insulin leads to over stimulation, the growth, development of organs, and these babies end up getting obese and overweight. And then obesity also leads to insulin resistance. So when these babies are obese, you find that the insulin itself is not effective. So you end up getting diabetes mellitus. So breastfeeding actually improves on the gut microbiome, so that the inflammation, whatever that causes, some challenges in this baby is also reduced. There was a question on other protective effects of breast milk. We know it has IgA, and it has some macrophages, the lysozymes, the interferons, which are very, very important for the infection control. I think basically, then there was a question on how breastfeeding actually causes it's a contraceptive technique. It is still related to suppression of estrogens and progesterones. When the baby is breastfeeding, there is increased release of prolactin, and prolactin suppresses ovulation, which leads to lactational amenorrhea. I think that's what I was able to pick out, but in case there are other questions, probably I haven't answered. There were very many. I would be happy to add on, but I think the presenters themselves can also expand on some of the questions that we raised relating to what they presented. Thank you, and back to you, Chair.
Okay, thank you so much, Dr. Tom, for that. That was very helpful. Round of applause for Dr. Tom. So I think as Dr. Kathy steps up to answer some of the questions that were posed by Dr. Tom, there are other few questions that I would like to add, which were also picked from the chat. And one of them is legal considerations for human donor milk. Also, they were asking, why is it that you separate the preterm and term donated milk? Like, why are they separate? Then the other thing was, is there any appreciation you give to the mothers that donate the milk to the different banks in the country? Finally, for you is, what is your comment about the use of IV amino acids in malnourished babies? Then the other questions will be answered by our other presenters. Thank you very much. Dr. Kathy, please.
Great. Thank you, Dr. Carol and Dr. Tom, for bringing those questions, and thank you for the people who asked them. So there's a lot here. Let me see if I can get them all. So preservatives, no, there's nothing in that milk apart from the breast milk itself. Through pasteurization, we remove dangerous bacteria. We remove viruses that we perhaps can't test for. One of the most important ones is cytomegalovirus, or CMV. That can be devastating if in a preterm baby, but it's very hard for us in Uganda to test for. But we know if we pasteurize, we remove that. To be clear, we also screen for HIV, syphilis, and hepatitis B before a mother becomes a donor. If we've already seen she's positive in our antenatal card, we don't progress any further. If she doesn't know or she's previously negative, we test for those things. In some countries, they test for hepatitis C, but there's currently no evidence that hepatitis C is transmitted via breast milk. That really is left over from blood donation. So the milk is pasteurized, it becomes very safe, and traditionally, expiry date is 6 months if you're going to use it for a preterm baby, and 12 months if you're going to use it for a term baby. But many people now are moving towards 6 months for all babies. In practice, milk doesn't stay in the milk bank longer than 2 or 3 months maximum because it's being used very quickly. But 6 months really is the limit of once you've pasteurized and frozen that milk. Question about selling the milk. This is really important point. Donor human milk should be free at point of donation and free at point of receipt, just like with blood. I alluded to it before, but in some countries, particularly in Asia, where they did start charging people and paying people for donor human milk, people would bring like diluted white paint, they would bring cow's milk, they would bring things that weren't breast milk in order to be paid. So if you're not checking, you might not know what you are putting into your milk bank. Another reason why we do directly observed donation in our human milk bank. Also, some mothers will donate their milk at the expense of their own baby, maybe give cow's milk to their baby because they know they can make more money for their family through donation. Yes, we do give a small appreciation to our mothers in Bali, maybe some baby clothes or maybe some Pampers, something like that. But that's not the reason they donate. We don't say, hey, if you give your milk, we'll give you something. Really, it's just a token of appreciation. And from the research done by Were Winfred, who was one of our MED MPH students at Busatima, really the mothers are wanting to donate because they have too much milk. It would go down the sink or it would go to waste. And yet that milk can save the life of another baby. So really, it's done for reasons of community and helping one another. Is donor human milk replacing breast milk and formula milk and cow's milk? No, it's not replacing it. And actually, it's much more expensive. If you can see that process that we go through of screening, expressing, pasteurizing, storing, 1 jar of donor human milk is actually relatively expensive. But what we're trying to do is prioritize human milk, whether it's mom's own milk or donor human milk, for the most vulnerable babies. That's our prematures, our surgical babies like gastroschisis, duodenal atresia, and babies who cannot get to their mother's milk because their mother has passed on and they're sick in the neonatal unit or the mother is on antipsychotics. Why do we separate the preterm and the term milk? Preterm milk has got different nutrition to term milk. So we want the preterm milk to go to the preterm babies.
Okay. Okay, I think Dr. Fatih has a few challenges as she returns to the call. Let's have Dr. Doreen answer some other questions. And the first one is, what is the science behind breastfeeding and risk of PPH in mothers? Then there's also a question about whether we still do NG aspiration before we give another feed to ensure adequate absorption. The other one was any preparations on market that help to increase breast milk production besides just expression. Also, what is the difference in composition between human milk and cow's milk? Yes. Then also, is warming breast milk okay, especially after it has been in a refrigerator for a long time? Yes, Dr. Doreen, please comment on that.
So breastfeeding and PPH, I will tell you a research I did when I was doing my master's among mothers who are C-section mothers, and there was this mother who had, she was a para-5, so it was her 5th baby, and after the C-section, the uterus had failed to contract, meaning the placental site where gaping blood vessels were waiting to gush out blood were, there was no constriction because of the contraction of the uterine muscle. So the gyne wisely asked the baby to be put on the breast. That released oxytocin and that contracted the uterus along with other measures. So this is how PPH is prevented by the release of oxytocin through the natural pathway that Dr. Ediamo has already described. And that is how PPH can be prevented, which is why we encourage early initiation of breastfeeding within the first hour, which is when the risk is highest. Preparations for increasing breast milk production are scientifically called galactogogues, and we need to be guided by evidence when choosing what to use. So there are two groups, there are pharmaceuticals and non-pharmaceuticals. Pharmaceuticals are usually drugs, they are dopamine antagonists, commonly metoclopramide or domperidone. However, these should be used with caution, they have their own side effects, mothers need to be assessed, but also you need to use them if there is a need. On another day, we can talk about indications for them, but we need to consider how they work and consider that prolactin is stimulated when the mother is given domperidone. The question is, if a mother's prolactin levels are normal, will you still give domperidone? Then when we look at non-pharmaceutical galactogogues, those are commonly foods, herbs, usually in the form of drinks or teas or pastries, the commonly now lactation cookies and teas and whatnot. What my take on this is that you need to understand how each of them works in order for you to know what you are trying to affect, so that if it's not necessary, you eliminate it, because herbs are also known to have medicinal effects. Now, there's a long list of herbs commonly used in the market are fenugreek, fennel, dandelion, milk thistle, in the form of silymarin. There are all sorts of herbs that are used, but my message to you is take care of the natural way breast milk is made and therefore increased. So you need to have a proper assessment of a mother before you throw anything at her. Is she emptying the breast frequently? Is she emptying the breast efficiently and thoroughly? That is what will cause that whole negative pathway to come into play to encourage production of breast milk. Take all these things we've talked about and do none of the latter, and we will not have a lasting effect. Warming breast milk. Ideally, if breast milk is at room temperature, there is no need to warm it. If you need to warm it, it is mostly if it is coming out of a fridge, although it can be given to the baby cold. Now, if a baby does not take it cold, then you can gently thaw it. So these are the protocols for thawing breast milk, which is frozen. If it's not frozen, a baby can take it as is, but if you choose to warm it, you just need to warm it in lukewarm water. Do not microwave, do not boil, do not heat on a fire source. So just bring this milk out of the freezer, put it in the fridge. It will thaw gently, preferably over 24 hours, and it can be fed to the baby, or it can be run under lukewarm water, not hot water, or placed in a bowl of warm water. There's no evidence that says, though, that you have to eat it. Thank you very much.
Okay, Dr. Doreen, thank you so much for that. Dr. Kathy has been able to answer her remaining questions in the chat, so please go through that so that we can conclude on the questions that she was answering. So finally, as we conclude, we're going to be able to do our post-test. It's going to reflect on your screen as it did earlier for the pre-test. I think you're able to see it right now. So kindly fill in those, kindly answer so that we're able to assess the knowledge gain during our discussion for this afternoon. So
She can make the correct answer, Dr. Doreen.
So for the post-test, we asked you a few questions, and the answer to question 1 is breast milk alone is sufficient for the first 6 months of life. I hope all of you got that correct. For the mother whose baby is 3 months old and she's returning to work, all the above responses were correct. So you have enough messages to share with the mother. Now, for the intervention, most important for supporting lactation in a mother following preterm birth when her infant is unable to breastfeed is to really encourage breast milk expression as soon as possible after birth and support frequent expression. The primary purpose, question 4, of a human milk bank is to provide safe pasteurized donor human milk for those who need it when a mother's own milk is temporarily unavailable or insufficient. This preterm who is 1,200 grams and their mother is producing very little milk, we asked you what the most appropriate action is. And our question would be to provide donor human milk if available, while continuing intensive lactation support, and encourage the mother to establish her own milk supply.
Okay, thank you very much. So as we conclude our session, we kindly request you to turn on your videos. We want to take a few screenshots for our session. So our dear participants, kindly turn on your videos. Yes, thank you so much. We want to take this opportunity to thank SEED Global Health, HOPE, and Ministry of Health for making these sessions possible. We are really, really glad to have been your discussants for that day. And thank you so much for being a very, very great audience. Thank you so much. Thank you so much, Dr. Kathy, for attending, despite not being here physically. We really appreciate your time. Thank you so much, Dr. Tom, for really, really answering to our questions. Yes. Thank you so much for turning on your videos. I'm seeing Nat is somewhere. Dr. Kathy. Dr. Kathy. Alice, thank you. Nelson. I can see Jemba. I can see Stephen. I can see Vincent, Philip, James, Alice. Yeah, thank you very much. Junior, Christopher, Anna, Solomon, Moses, Maria. Thank you so much for attending. Nahora, I can see Nandaula. Thank you so much for being a very great audience.